Hello and welcome back. So today we'll be discussing a generalized diagnostic framework for the evaluation of lymphadenopathy with or without splenomegaly. So this is a continuation of my general approach to symptoms and signs. This obviously being a sign. Uh, so the topics that I'll be covering today will be we'll be trying to understand why I have considered the diagnostic frameworks for lymphadenopathy and splenomegaly together. Why I'm going to derive them together. Second, we'll try to deduce the causes of lymphadenopathy and splenomegaly, which are secondary to one, immune activation, two, increased phagocytic function, three, ineffective erythropoiesis, four, infiltration of the lymph nodes or the spleen by a cellular or a non-cellular process. And we'll try to understand why generalized lymphadenopathy and massive splenomegaly require special consideration. And finally, I'll have a final word on lymphadenopathy in rheumatoid arthritis in SLE. Okay, so first, coming to our first question, why construct a diagnostic framework for both of these pathologies together? So both together constitute what we call secondary lymphoid organs. And these are organs where mature lymphocytes are exposed to antigen and undergo antigen dependent development. Now, you may have noticed that I'm actually, slowly but steadily working my way towards a discussion on the structure and function of the immune system. But I want, a good background in prior to getting into the specific discussions at hand when we discuss that. So I'll be discussing that at a later date. So now, however, the spleen differs from the lymph nodes in two important functional aspects. Okay, that is, it performs two additional functions. One is hematopoiesis, that is, it functions as a primary lymphoid organ. That is where lymphocytes and blood cells are produced primarily from week 8 to week 28 of intrauterine life. So when in an adult you have situations in which the bone marrow is not able to maintain normal hematopoiesis, at that point the hematopoietic stem cells can actually shift over to the spleen and use it as a site of extramedullary hematopoiesis. Then it also removes old and defective cells from circulation. This is particularly true for RBCs, but so is it for other cells. So it has a quote-unquote phagocytic function. Obviously, it is the phagocytes within the spleen that have the phagocytic function, but it has a phagocytic function. Okay. Thus, the causes of generalized lymphadenopathy and splenomegaly naturally overlap, but there is only partial overlap. So let's talk about the mechanisms, generalized lymphadenopathy and splenomegaly. So first mechanism is lymphoid cell proliferation due to immune activation. Now, this is obviously going to cause generalized lymphadenopathy. This is also going to cause splenomegaly. Second is increased RBC phagocytosis. So phagocytosis only happens in the spleen. So that this doesn't cause generalized lymphadenopathy, but it does cause splenomegaly. Then we have extramedullary hematopoiesis. At no point during intrauterine development does the lymph nodes function as a primary lymphoid organ. So extramedullary hematopoiesis usually will not initially at least occur in lymph nodes, and they definitely will not cause generalized lymphadenopathy. So no. But the spleen, as I've just discussed, can function as a site for extramedullary hematopoiesis. So yes. Then cellular or non-cellular infiltration. Obviously both sites are vascularized, so they can be infiltrated by cells or non-cellular infiltrate. However, the type of infiltrate will differ depending on the primary location or that we are considering. That we'll get to just now. Now, let's start with the first entity, that is in situ cellular proliferation due to excess immune activation. So obviously this could be secondary to an infection. It could be secondary without a secondary to a primary infection as a driving source. So first we'll consider the non-infectious causes, get them out of the way, and then go to the infections. So this type of immune activation could be a part of systemic autoimmune disorders. It could be a part of organ-limited autoimmune disorders. It could be a part of autoinflammatory disorders, primary immunodeficiency disorders, and lymphoproliferative disorders. Okay. So among the autoimmune disorders, as obviously I have already alluded to, rheumatoid arthritis and SLE notably do cause lymphadenopathy, but there are caveats to that general assumption. Then obviously sarcoidosis is well known to cause generalized lymphadenopathy. Similarly, the primary alpha interferonopathies also can cause generalized lymphadenopathy, but they don't usually cause splenomegaly. This is an important distinction. Among organ-limited autoimmune disorders, the most common is obviously autoimmune thyroiditis. So this is more of a correlation rather than causation, but still it has been described as a cause in Harrison. Then primary biliary cholangitis causes localized as well as generalized lymphadenopathy. Kawasaki disease naturally causes generalized lymphadenopathy, and familial Mediterranean fever syndromes, familial Mediterranean fever and other autoinflammatory syndromes, monogenic autoinflammatory syndromes do cause it, particularly hyper IgD syndrome and mevalonic aciduria. So we'll get to that when we get to it. On the other hand, splenomegaly is prominently a part of autoimmune hemolytic anemia or autoimmune thrombocytopenia, and lymphadenopathy typically is not. Okay, autoimmune neutropenia also can be associated with splenomegaly. Okay, now among primary immunodeficiencies, it is any opportunistic infection. We'll just get to that subsequently. And an important consideration under this category is the autoimmune lymphoproliferative syndrome, or ALPS. Now, in case of lymphoproliferative disorders, although I'm describing angioimmunoblastic lymphoma here, it's actually a T cell malignancy. So we'll get to that later. But there is a type of immune activation occurring there. Secondary reactive B cell activation is happening. Now, similarly, other malignancies like lymphocytic granulomatosis also can have that effect, which is a variant of DLBCL, that is diffuse large B cell lymphoma. We'll get to that. And also Castleman's disease, which is a plasma cell dyscrasia, Rosai-Dorfman disease, which is a lymph node specific histiocytosis, and Kikuchi-Fujimoto disease, which is a lymph node specific alpha interferonopathy. So we'll get to these disorders in subsequent discussions on these in this series. Now coming to our infections. Now among infections, practically any infection can cause either or. Okay. Particularly bacterial infection, but there are some that we need special consideration because they are more common, they're more likely to present like this. Okay, so I use the mnemonic taste chai because I'm being an Indian, I'm quite fond of tea. So taste stands for T for tuberculosis, A for abscess, that is splenic abscess, S for sepsis or subacute bacterial endocarditis, T for tertiary syphilis, E for ehrlichiosis, which we don't see in India, but I needed to complete the mnemonic. And CHAI stands for 4 viral infections, that is cytomegalovirus, hepatitis virus, human immunodeficiency virus related autoimmune, acquired immunodeficiency syndrome, and infectious mononucleosis. Now, importantly, it is actually when prior to the development of AIDS in HIV infections that you develop generalized lymphadenopathy. Okay. Now, other viruses that can cause it are obviously the measles, mumps, and rubella viruses, adenoviruses, and DNA viruses, particularly herpes viruses. Okay. Then we have fungal infections. In India, essentially, histoplasmosis is the only endemic fungal infection that we routinely see. Abroad in the US, coccidioidomycosis and paracoccidioidomycosis both are relevant in that context, but not in India. Okay. And then we have parasitic infections. Importantly, leishmaniasis is something that we need to be aware of. Lymphadenopathy has not been actually described as often in Indian patients with the leishmaniasis or Kala-Azar, but still it is something that needs to be considered. Then toxoplasmosis, trypanosomiasis, and filariasis are the other causes. Malaria causes a type of massive splenomegaly called tropical splenomegaly, or usually associated with quartan malaria. Now, in situ cellular proliferation may also be due to excessive phagocytic function, and obviously normal lymph nodes don't have phagocytic function, so it would be very odd to have lymphadenopathy due corresponding with increased phagocytic function. Okay, so they are usually spared. So conditions with excessive phagocytosis in the spleen may themselves also be immune mediated. So in that context, you could get some category of lymphadenopathy. And in such an eventuality, the increase in splenic size is both due to immune activation as well as the increased phagocytic function. So often that correlates with very large spleen size, as we'll get to subsequently. So this includes extravascular hemolysis. In intravascular hemolysis, we'll discuss sometimes in PNH you can get it, and it has been quoted as a cause. But intravascular hemolysis typically is not associated with splenomegaly. Okay, so it's an uncommon thing to find in intravascular hemolysis. And then ineffective erythropoiesis. Also, there is extramedullary hematopoiesis in these situations. So that is another cause of the splenomegaly. Then lymph nodes cannot support extramedullary hematopoiesis, as we've discussed. So they are again spared when we are talking about extramedullary hematopoiesis. So if there is ineffective erythropoiesis in the bone marrow, then extramedullary hematopoiesis obviously will affect the spleen, or it will cause splenomegaly, but it will not cause significant lymphadenopathy. Now, cellular and non-cellular infiltration may cause either and or lymph node or splenic enlargement. It depends on the type of infiltrate. So let's talk about cellular infiltrate and non-cellular infiltrate separately. Primarily, I'm talking now about malignant infiltrate, because we've already discussed immune infiltrate, because that was corresponding to immune activation. Okay, so let's see. So any hematological malignancies, particularly myeloproliferative disorders, can cause both lymphadenopathy and splenomegaly. Myeloproliferative disorders specifically cause splenomegaly, and we'll have dedicated discussions on B cell lymphomas, mature B cell lymphomas, mature T cell lymphomas, histiocytic dendritic cell neoplasms, and obviously the myeloproliferative neoplasms subsequently in this series. Then solid tumor metastasis, sometimes presenting as a carcinoma of unknown primary. Both of these can cause both lymphadenopathy and splenomegaly. Now, there are a few cause tumors that specifically affect the spleen, and they can cause splenomegaly. That could be a splenic angiosarcoma, exceedingly rare, a hemangioma, fibroma, lymphangioma, or a again I've mentioned fibroma twice here. Okay. Then now importantly, Langerhans histiocytosis is a type of histiocytic or dendritic cell neoplasm. So that can cause both lymphadenopathy and splenomegaly. But again, it's a little odd in these conditions to develop either of these two. Now, non-cellular infiltrate essentially is of three disorders. I remember it using the mnemonic glyceryl trinitrate. Okay, that is GTN. So that is Gaucher's disease, Tangiers disease, and Niemann-Pick's disease. Additionally, Fabry's has been documented to cause it. So that also can cause both hepatosplenomegaly as well as lymphadenopathy, but it's not as prominent as in the other disorders. Then a familial hypertriglyceridemia typically causes generalized lymphadenopathy, and amyloidosis can cause either or. Now, importantly, in amyloidosis, the spleen is large, but it is functionally ineffective. So the patient actually may have features of hyposplenism, that is increased counts, the presence of Dolly bodies and things like that, which will come to in our subsequent discussions. Now, why does generalized lymphadenopathy and massive splenomegaly, why do they require special consideration? Because they have very specific causes, and that narrows down a differential very significantly. So generalized lymphadenopathy, I remember using the mnemonic, again, smelled chai. Earlier I tasted chai, now we smell chai. Okay, so smelled chai stands for S for SLE, M for MCTD, L for any lymphoma, absolutely any. Okay, T stands for toxoplasmosis, C stands for chai is all infection. So again, it's the same thing actually. That is CMV, hepatitis, AIDS, and infectious mononucleosis. So these are the same causes of chai that I discussed earlier, and smelt is different here. Okay. Whereas massive splenomegaly, now massive splenomegaly is actually defined based on the weight of the spleen. That is more than 1 gram, so 1 kilogram. That is 1,000 grams. However, there are other clinical correlates. For example, a spleen that crosses the umbilicus, usually longer than the tip of the spleen from the left costal margin, is the maximum distance is more than 7 centimeters. So that is what is called a massive splenomegaly. But strictly speaking, it is the weight. Okay, but these are the causes, and that narrows it down very significantly. So how I remember it is I use the mnemonic: sensible guys avoid paracetamol in CLD naturally. Okay, so S stands for sensible. S stands for sarcoidosis. G stands for Gaucher's disease. Avoid. A stands for autoimmune hemolytic anemia. So you can see in sarcoidosis we have immune activation, very significant immune activation, and infiltration of granulomas into the spleen. So that is why there is massive splenomegaly. In Gauchers, we have some immune activation and very significant infiltration. That is why we have massive splenomegaly. In autoimmune hemolytic anemia, we have immune activation and we have increased splenic phagocytic function. That is why we have massive splenomegaly. Okay. Then PCM stands for the myeloproliferative disorders. That is primary polycythemia vera, chronic myeloid leukemia, and obviously myelofibrosis. That is primary. Okay. And CLD stands for C for CLL. Okay. L for CLL being chronic lymphoid leukemia. L for any other lymphoma, and D is actually the least important cause, that is diffuse splenic angiomatosis. Okay, so of this, when describing the causes, even though this is the mnemonic I use, I try to say these as the last two entities in the quote unquote list. Okay, because they are the least common, but they are definite causes of massive splenomegaly. Now, what I've covered now is we've understood why I derive the diagnostic frameworks of splenomegaly and lymphadenopathy together. Second, we've deduced the causes of lymphadenopathy and splenomegaly. One, due to immune activation, which we divided into not secondary to infection and secondary to infection. Increased phagocytic function, which obviously only causes splenomegaly. Ineffective erythropoiesis resulting in extramedullary hematopoiesis, which again often only caused splenomegaly. Then infiltration of the lymph node and the spleen. So the lymphadenopathy in RA and SLE will compare them directly to each other. So the prevalence is in RA it's around 5 to 10%. In SLE it's less than 5%. Association with disease activity is plus minus in RA. It is typically associated with disease activity in SLE. The type is, when you look at the lymph nodes, you find follicular hyperplasia. Okay, and you'll have to take my word for it now, but in the next discussion we'll be delving into this little in great detail. Then in case of SLE, we find paracortical hyperplasia and with or without confluent necrosis. And marker of poor prognosis, they are only markers of poor prognosis if there is localized massive lymphadenopathy, which probably indicates conversion to a lymphoma. Now, for the bonus section, that is, what do I mean by this follicular hyperplasia, paracortical hyperplasia, etc. So this is your normal lymph node structure. So these are the afferent lymphatic channels that are bringing lymph to the lymph node. This is the efferent, that is taking away lymph from the lymph node. Now within the lymph node, we find some very interesting structures. We find this meshwork of fibers, these that are made blue, that are the reticulin fibers, and there is this is the capsule that enmeshes the lymph node. So underneath the capsule you have a subcortical sinus, and that subcortical sinus is actually continuing towards the hilum as separate sinuses. Okay, then in between the sinuses we actually have some structures, and we'll see what those structures are. So now I've filled in the diagram. So actually what this is this. These are the cortex. So the outermost, obviously by convention, the outermost structure here is the cortex. So the cortex here, in case the lymph node cortex, contains your parafollicular T cell zones, as well as the actual germinal centers. Okay, that is the follicles. So the follicles here I have shown as primary follicles and secondary follicles. So primary follicles don't necessarily have a germinal center. Okay, and secondary follicles start to have a germinal center and show some degree of germinal center polarization. So if you can see this particular germinal center, there is a darker blue region that is called the dark zone, basal dark zone, and there is a lighter region that is the apical light zone. Then we have the paracortex. Now the paracortex is deeper to, or more towards the efferent lymphatic vessel at the hilum of the lymph node as compared to the cortex. And so this is the paracortex, and it basically contains only a T cell zone. So this is your this is your follicle, and the follicle has certain other parts that we'll get to in the next discussion. But these are the cortex contains the follicles and the parafollicular T cell zones. Whereas what I've shaded here as because the color of lymphocytes is they're basophilic. So what I've colored in a basophilic color is the paracortical T cell zone. Okay. Now deeper to that, these sinuses all come together into a into the hilum and then drain into the efferent lymphatic. Now in the hilum, I've also shown the cross section of certain blood vessels, and this is what a section through a lymph node actually looks like. So these are the branches of the artery that is supplying this particular lymph node. Okay, so that is the general structure, and this everything deeper to this here is called the medulla. So the lymph node again has got a cortex, it's got a paracortex, and it's got a medulla. The paracortex is what contains the follicles, and around the follicles we have a T cell zone that is called the parafollicular T cell zone. Then we have the paracortex. The paracortex is essentially only contains the T cell zone, and then there are the sinuses, the paracortical sinuses. Okay, and then we have the medulla. The medulla contains the hilum essentially, and the hilar sinus, which extends into the efferent the lymphatics. So that is the the structure of the lymph node. Now this, like I've labeled, is what is called the subcapsular sinus. This is what is called the cortical sinus. Okay, and this is what is called the medullary sinus naturally, okay, because of its location. This is what is called the hilum of the lymph node. And finally, I have some interesting, we divide pathologies of the lymph node into 4 distributions or quote unquote patterns, and we'll just highlight what those patterns are. So one is follicular. Okay, that would obviously indicate something around the follicles present within the cortex. Second is paracortical. So naturally that would affect the paracortical T cell zone, as I've shown in the diagram. The third is sinus. Okay, so that would affect the sinus, either the subcapsular sinus at any point, starting anywhere here. Okay, so the third is a sinus. Okay, so finally, obviously the fourth is obviously a mixed pattern. So the 3 main patterns are the cortical, the paracortical, and the sinus pattern, and finally we've got our mixed pattern. So in the next discussion we'll be delving into the histopathology of and how we deduce the causes of lymphadenopathy from the histopathology of these disorders, and how we use that in a clinical setting. Lymphadenopathy is something in which it's very easy often to take a histopathological sample and gives a lot of information, but again, like any other investigation, it has to be assessed in the background of the pretest probability or whatever you're considering. So that is why I have taken pains to first enumerate the causes of generalized lymphadenopathy, massive splenomegaly, and lymphadenopathy and splenomegaly in general as well. And then in the next discussion we'll talk about what the histopathological findings might be. So I'll see you in that discussion. Thank you for watching.